There we go. All right, yes, so us medical students are multifaceted. We're not just medicine. We are also humans and people. So we wanted to create this medical student grants rounds for people to talk about their passions, sometimes within medicine, sometimes out of medicine. So medical student is Ben, who will be introduced by Dr. Haycock. And it's typically the third Tuesday of each month at 12 p.m., and the first Tuesdays will be scheduled on a month-to-month basis. We are doing a hybrid now, exciting. COVID's not over, but we are vaccinated. Here we go. So if you want to nominate a presenter, you can use that link, and then we will post the YouTube videos within a week after the presentation. All right, and then next week, or September 20th, we will be having Dr. Marcus Harrigan, who is what year is that? Third year at this point, who will be talking about the acute spinal cord injuries and muscle wasting. So I would like to pass it off to Dr. Haycock, who's going to be introducing student Dr. Ben.
Good afternoon. I hope you guys enjoyed the talk. I have the pleasure of introducing you to Ben today. He's a fourth-year student from Iowa. He went to Iowa State, graduated in nutritional sciences, as did I, actually. I don't know if we've talked about that, and genetics. He was chosen in his first year to join a cohort of students to do our Choosing Wisely STARS program. It's a program that's open to all first-year students. It's application-based, and they get to learn more about high-value care and how to implement the curriculum. We had 2 students at that time, and Ben was a true leader in that. And that the next year, he built our mentoring program to help the students that followed him, and also works for Cost of Care as their social media advisor. And then he's become known by Cost of Care, which is an organization across the nation that looks at high-value care, as a leader, a student leader in this group, and is their current student advisor. He also recently just got an award called the STARS Student Excellence Award. This is the first year they are giving out those awards, and I have to say his name is really well known within the community. On top of that, I was also looking, and he's gotten the Dr. James Hutchinson Endowed Scholarship. He's an AOA. He's got the Landacre Honor Society research. He's in the Landacre Research Honor Society, and also got the Ring to Candy Apple Award. So he's really distinguished, and I have to say I learn from him on this topic every day. We talk about it. So I will give you Ben.
Thank you for that introduction, Dr. Haycock. If you could come and do that at my residency interviews, that would be helpful. And thanks to Student Council for hosting these events. I think this is a really cool platform and kind of something that's unique to OSU, where students get to highlight their passions and the things that they're working on. So again, if we haven't met before, I'm Ben. I'm one of the fourth years going into psychiatry. And today we're going to be talking about kind of a lot of different threads, different themes that have run through my medical school experience. Going to talk a little bit about medical ethics and this idea of do no harm. We'll talk about medical students as affordability change agents, what high-value care means, and kind of tie all that together and what it means specifically for us as medical students. Before we kind of get into the meat of the talk, though, and the nitty-gritty details about what's high-value care, what does healthcare affordability look like, I wanted to talk kind of about my journey to healthcare affordability and how this became an important topic for me. And that starts off with this picture of me in a tutu. For those of you who have taken our course, you've seen this picture before. I have one older brother, Zach, and 2 younger sisters, Ella and Jenna, both of whom are adopted from Guatemala. And this is my youngest sister, Jenna. When Jenna was towards the tail end of middle school and then at the beginning of high school, she experienced some pretty significant mental health challenges. And we were living in the state of Iowa at the time, and in the state of Iowa, there's kind of 3 levels of pediatric mental health care. There's crisis care, which happens typically in the emergency department. There's kind of an intermediate crisis stabilization unit, which pediatric patients will go there. They'll spend typically up to a week at those facilities, and then they're safe to go home. And then there's long-term treatment facilities where children stay for weeks to months to get medication, therapy, things like that. Jenna had 3 stays at long-term treatment facilities, and I think this was taken during the 2nd stay that she had. And a group of patients from the facility decided to do like a couch to 5K type program, and they only did it if I agreed to be the leader and if I agreed to wear a tutu with them. So that was kind of the background for this. But where affordability ties in is that Jenna had a pretty extended stay at one of these kind of intermediate treatment facilities. So these are facilities designed really for crisis stabilization. They hold patients there for up to a week at a time. And Jenna was waiting for a bed at a long-term treatment facility, and she waited there for 31 days. That's actually the record in the state of Iowa. She stayed there longer than any patient before her. And this was happening kind of amidst my pre-med career. I was a bright-eyed, bushy-tailed pre-med student ready to save the world and change all these things in medicine. And I was actually home over Thanksgiving break. And my parents showed me the bill from Jenna's stay at this facility. And I don't remember the exact amount anymore, but it was well over $60,000 that we were expected to pay for her care. And so here I was, this like bright-eyed, bushy-tailed pre-med student ready to change the world. And I was like, medicine's great, like we always help people. And I kind of had to morally and ethically deal with this other side, that like my sister was getting this very much needed mental health care, but our family was going to be ruined financially by this. Luckily, it was paid for through a program that's kind of like Medicaid in the state of Iowa, but both my parents were teachers. Like we didn't have the money to spend $60,000 on this healthcare bill. So that's kind of like what got the wheels turning, and that's the experience that initially led me to this work, and a tutu was certainly involved. And then in terms of getting to medical school and kind of what my journey through value and affordability has looked like. This is where it starts. So I got here in August 2019, joined the College of Medicine then, and in November 2019 had the opportunity to join the STARS program. Got this email talking about the Students and Trainees Advocating for Resource Stewardship program, and had the opportunity to join that, apply for that. And we actually, in January 2020, went to Austin, Texas for our first leadership summit. That's kind of what kicks off the program. Ate our body weight in barbecue there, ate a bunch of great breakfast tacos. It was a really fun time. But then we came back from that leadership summit, and we had to come up with a curricular project or something we were going to do during our time in the program. And Michael Yeager, who is my co-star, a first-year family medicine resident here at OSU, we were kind of thinking about, like, where can we fit things into the curriculum? Like, you've all experienced it, that it can be kind of clunky at times. There's different parts that we have to try to fit ourselves into. And so we actually reflected on our selective experience. These are elective courses that students take, typically 2 to 3 days in their first and second years of medical school. And we thought that might be kind of a good like plug-and-play type option. We can fit our curriculum into that and make some changes there. And so from January 2020 up until October 2020, we worked on developing the course, developing the lectures. We recruited faculty members to take part in the course. And then in October 2020, finally taught the course to both first and second year medical students. And then we did some pre and post course evaluations as well. So that was kind of my tenure in the STARS program as a participant. And then November 2020 rolled around, and it's a year-long program, and it was kind of time for things to be done. And so I sat down with Dr. Haycock, and we kind of had a conversation about my goals in terms of leadership and mentorship and how that fit in with the program. And we decided that I was going to stay on, and Michael stayed on as well, as peer mentors for the program. And so we work with the next cohort of students, and now it's cool that our 2021 cohort has stayed on to work with our 2022 cohort, and we have kind of this tiered mentorship program where we all share our experiences. We share what we've learned, we share our insights to help kind of further our projects in terms of value and affordability. And then in December 2020, I got an email from the folks at Cost of Care. Cost of Care is one of the nation's leading nonprofits working on issues related to healthcare value and affordability. And they're the ones who help to fund and really run the STARS program in its entirety. And I got this email saying like, hey, like you've done some cool work through the STARS program. We'd like to have you join our team as a social media manager. And so I started working on projects on Facebook and Twitter and Instagram and LinkedIn. And for the students in the audience, whether you're online or in person, like probably 1 or 2 times during medical school, you'll be presented with like a really life-changing opportunity, like a really great chance. And I remember getting that email, and I was looking at my calendar for the spring, and I was like, I don't quite know if I have the time to do this. I'm not sure if I'm ready to do this. And I encourage you, like when you get that opportunity, to take that leap, because working with Cost of Care has by far been one of the most meaningful and just a really incredible opportunity during medical school. So I joined their team in December 2020 as a social media manager, working again on kind of all those projects. Then January 2021 rolled around. This COVID thing was happening and kind of in full swing. I really wish we got to go back to Austin, but instead we had the 2021 STARS Leadership Summit virtually over Zoom. I had the opportunity to give a talk there, looking at value and affordability and social media and kind of tying all that up in terms of advocacy and how students can be advocates in those realms. So we did that in January 2021, and then in October 2021, we looked at our pre and post course data, kind of tied all that up and looked at it in terms of what it meant for our teaching and what changes we were going to make in the future, and we presented that at the High Value Practice Academic Alliance meeting, which was virtual again. In January 2022, we kind of looked at that data for another time, and we looked at it through the lens of diversity and inclusion. Like, what are we doing in our work to make sure that affordability and value are looked at as equity issues, to make sure that we're serving all of our patients in these different ways. And we presented that work again at the College of Medicine's Annual Education Symposium. And then this past May, I had a really great opportunity to work with some of our 2022 stars. and to kind of tie all of our stuff together and look at it from, come on, you're good. We looked at it from a teaching and learning perspective. So we had the opportunity to present our work it's actually an OSU-wide conference for the Institute for Teaching and Learning. And we pulled all that together and kind of talked about the lessons that we learned teaching this content during the COVID-19 pandemic. Then in October 2022, I'm excited to share that we actually had 2 abstracts accepted. So both our 2021 and 2022 stars put together abstracts, had those accepted, again, for the High Value Practice Academic Alliance, which I think is happening in person in Baltimore, but will also be online as well. And then in terms of the future for this work, at least for me, there's this pesky little ERAS application that's due in a few weeks. I should probably finish up and start looking at some of these topics in terms of working as a psychiatry resident and what it means for psychiatry patients. In terms of lessons, though, especially for our first and second year students that are in the audience, whether you're online or in person, I think 2 things to take away from this. The first thing being that success or whatever you want to pursue, it's going to take time. I started projects in November 2019 that are still running. There's still things going on. There's still things that we haven't finished up yet. And so I think, I was really frustrated in 2020 when I didn't have abstracts, I didn't have posters, I didn't have things to put on, my CV yet. But, because as you watch as this kind of matures and as things happen with your projects, things take time to be successful. And then secondly, I encourage you in whatever you're doing, if it's clinical work, if it's research work, if it's advocacy, to really engage with a team, work with a team. We have folks literally all across the country, everybody from first-year medical students to emeritus professors, working on issues related to value and affordability. And I think, if you embrace that team mindset, I think the old adage that if you want to go, if you want to go fast, go alone. If you want to go far, go with a team. I think that really applies to the work that you do as a medical student. So that's kind of my journey through value and affordability in medical school and how we got to where we are today. In terms of the meat of the presentation, we're going to talk a little bit about the current state of healthcare affordability. I think we really need to define where we're at now in terms of, then discussing where we want to go in the future. We'll talk about the value shortfall and this concept of everyday affordability. I encourage you, as we talk about these topics, to think about the people in your life where healthcare affordability really matters to them. Think about your mailman, think about the people that stock the shelves at your grocery store, your kids' teachers, all of those people. What does affordability look like for everyday Americans? We'll talk a little bit about overtreatment and healthcare waste as well. That's kind of another part of the equation that's difficult to handle, but it's important to talk about too. We'll talk about where do we go from here. There's a lot of doom and gloom in these first couple of slides, but we'll talk about some options for moving forward. And then I'll cover a model that we use at Cost of Care to help medical students become change agents in terms of affordability and value. And that has a foundation of trust. We'll talk about awareness, appropriateness, and affordability, and then ultimately our goal as well. And then this is kind of my senior send-off. I have a few months here at the College of Medicine. So I'm going to lay out a couple challenges for the College of Medicine and for the Medical Center, some areas where I really think that we can improve and really improve our patients' lives. So I'll talk about those and how they relate to affordability, education, and implementation. And if anybody gets excited by any of those, we should talk about those after the presentation's done. So the first thing to know, if you take anything away from this presentation, it's this definition for value-based healthcare. So when we talk about healthcare value and we talk about high-value care, this is what we're looking at specifically, is the outcomes that matter to patients over the total cost of care. So these are the things that we're considering. Are we reaching the outcomes that really matter to patients? Is their disease better? Are their symptoms better? And then we're thinking about the total cost of care. How much does it cost with their insurance? How much time do they have to take off of work? What do transportation costs look like? Kind of all these things wrapped together. And when we look at those outcomes that matter to patients over the total cost of care, then we're able to kind of derive the value of that care. And in the U.S., we have something called the value shortfall. Many of you have probably seen variations of this graph. Over on the y-axis, we have higher health system performance on the top and lower health system performance on the bottom. And then on the x-axis, we go from lower healthcare spending all the way to higher healthcare spending. And you'll see that there's one country that doesn't really fit in, and that's the United States. We spend more money than everybody else on healthcare, and we have the worst outcomes. And this is kind of a composite metric. It looks at things like maternal mortality and hospital readmission rates and ER visits and all of these things. And this is a value shortfall. This is the fact that we are spending more money than everybody else, and we're getting worse outcomes, even though we spend that much. And this is always a really striking statistic. We share this at the beginning of our courses, and students can be shocked by it, but it's really impersonal. Some of you will go to LP next week, some of you will see patients in the hospital, you'll see patients in a clinic, and you're like, what does this mean for the patient in front of me? And so when it comes to affordability and value, again, I want you to think about what it means for everyday Americans. and kind of what that personal impact means. We share this story on the left-hand side, kind of just as a funny thing, as an example of when healthcare spending can go awry. This is actually a child who was getting sedation for another procedure, and the hospital had agreed to pierce their ears under some contract that they had, and it ends up costing almost $2,000. What's going on there? This just seems like a crazy story. But it's a good example of kind of unnecessary treatments and things that we do in our healthcare system. But when it comes to the personal impact, these things matter for our patients who need insulin. They matter for patients over in the James who are on chemotherapy. They matter for our patients in the Ross who just had a heart attack and need to afford their medications afterwards. Affordability and these topics ultimately have a personal impact. So when it comes to affordability for everyday Americans, for folks that you encounter in the halls of our medical center, when we look at Americans, both insured and uninsured, so we take all comers, aged 18 to 64, how many of them have difficulty paying their medical bills? It ends up being about 1 in 4. And you're like, okay, Ben, you're cheating with the statistics, you included the uninsured group in there. What does it mean when we look at insured Americans? And when we look at insured Americans, about 1 in 5 of them will have difficulty paying their medical bills. So you'll get that list of 15 patients that you're going to round on in the hospital tomorrow morning, or your LP site that has 20 patients at clinic. 1 in 5 of them will have difficulty paying their medical bills. So that's something to consider. As you think about the number of patients you'll see really throughout your career in medical school, this is going to be a significant problem for a significant number of patients that you see kind of throughout your clinical experiences. And then when we look at who can afford it, I'm just going to show one particular example here to kind of give you an idea of what we think about when we talk about affordability. And this is actually one of my favorite graphs. So we have US dollars over on the y-axis there, and then we're going to look at a couple of different categories here. And the first one is the out-of-pocket maximum for the 2019 Affordable Care Act Bronze Plan. So this is a health insurance plan you get through the Affordable Care Act marketplace, fairly standard insurance plan that almost any American could go out and get. And their out-of-pocket maximum for 1 year, so you have catastrophic health events, you're in a car accident, somebody's diagnosed with cancer, you have a heart attack, and you have an extended stay in the hospital. The out-of-pocket maximum on that plan is around $8,000. So that's how much you could be expected to pay in out-of-pocket expenses. And then we're going to compare that to something called individual liquid assets. And this is a financial term that basically means the money you have on hand to deal with expenses. So, you have to take your pet to the vet, your car breaks down, you're hospitalized. Whatever expense you might have, this is kind of the money that you have on hand to pay for those expenses. And it means you don't have to sell your car, you don't have to sell your home, you don't have to take out a loan. This is the money that you have on hand. When you look at the median individual liquid assets for an American, this is a little bit dated, but it's from 2016. Median American has about $2,000. So that's how much they have to spend in terms of these surprise expenses that may come up. When we look at folks who are at less than 150% of the federal poverty line, they have a couple $100 on hand. And this is many of the patients that we care for, especially at OSU. They'll have a couple $100 available to spend on expenses like this. When we look at 150 to 400% of the federal poverty line, we're back up into that $2,000 range. Folks have some money, but nowhere near this $8,000 out-of-pocket maximum. And it's not until we get about 400% of the federal poverty line that folks, on average, would have individual liquid assets available to pay for these expenses. And when you're looking at the proportions of who fits into all of these categories, folks that are less than 400% of the federal poverty line, this is 60% of Americans. 60% of Americans, if they were to have this particular health insurance plan, if they were to go to the hospital, have some sort of catastrophic health expenditure, 60% of them would not have the money on hand in order to afford this care. And deductibles aren't getting any better. The best thing about health insurance is you pay for it every month, and then you have to pay more before it even kicks in. When we look at deductibles, they aren't getting any better either. And since 2008 in particular, for folks who get their health insurance through their workplace, which is the majority of Americans, annual deductibles have increased 8 times as fast as wages. And just a quick Google search, since this is going back to 2018, if you look at the news in 2022, the cost of premiums and deductibles are an increasing burden on Americans. High deductible plans increase out-of-pocket spending, and there's this concept known as the negative spiral of high deductible plans, where folks won't get preventative care or they won't address issues early on because they're worried about paying that deductible, and then it spirals from there and they're hospitalized or they have some sort of catastrophic health event and they have to end up paying even more, which may still not be covered depending on how high your deductible is. And what do people do when they can't afford their care? So we've looked at these things saying that a fair amount of people can't afford their care or they may not be able to. A few categories of actions for what everyday Americans do when they can't afford their health care. 70% will cut spending on food, clothing, household basic items. 60% will put off necessary health care. And this isn't just the convenient health care or hey, I went in because I had a cough. These are follow-up visits for chronic conditions. This is cancer screenings. They're follow-up visits after you go to the hospital. 60% of folks will put off necessary health care. 59% will use up all of their savings. This is probably one of the most heartbreaking things that I've experienced during medical school, and in particular when this happens at our children's hospital. When you talk to families who are looking at, the opportunity for their child to get care or using up all of their savings, these are really difficult conversations to have. I've had conversations with families who sold cars in order to afford their medical care, families who sold their homes, and I think probably the most distressing one was actually a patient over at the James, where it was like a family with like a legacy farm. They had been farmers their whole life, and somebody was diagnosed with cancer and had accrued medical bills through that, and they were looking at selling their family farm in order to afford those bills. These are real life folks who you'll encounter throughout your clinical scenarios, and we'll talk about how to talk with them about those things as well. 43% of folks won't fill prescriptions or they'll skip needed tests, and then 34% will cut pills in half as well to make their prescriptions last longer. So when you think about people who can't afford their care, like what's the next step, like what are they actually going to do when they need care, these are the sorts of things that we're looking at. And altogether, the take-home point from this, and especially for the students in the room, I want you to recognize that financial harms are real harms. All of you have done the sketchy videos where you see the side effects for the medications. You know what those are. When you get into your third and fourth years, you'll talk with patients about the risks and benefits of procedures or surgeries, and we do these things all the time. And I think in the modern American healthcare system, we have to recognize that financial harms are real harms too for our patients. Well, we exist in kind of this weird healthcare system where it's actually happening. I was going to say it could be a possibility, but it is happening, that folks are receiving too much care as well. The U.S. population is about 300 million people. That's our most current estimate. And collectively, we undergo 15 million nuclear medicine scans a year, 100 million CT and MRI scans, and almost 10 billion laboratory tests annually. And the Institute of Medicine estimates that over $750 billion is spent each year in the U.S. on healthcare waste. That's $2,300 for every single man, woman, and child in the U.S., and approximately 30% of total healthcare dollars in the U.S. are spent on waste. So we're kind of existing in this weird world where we have this group of Americans who can't afford their care, who can't get needed care, but then in a lot of ways we're also providing too much care. We're providing wasteful care that isn't coordinated. And Dr. Atul Gawande, who's a surgeon, researcher, writer, many of you have probably read his books. He actually did kind of the case study looking at McAllen, Texas. So he looked at a city that had higher healthcare expenditures than other cities all across the country, and for a lot of these reasons, because they were providing wasteful care in particular. And you're like, we want to make sure that people get needed care, but when do we know that we've gone, over the line? And he wrote in his piece for the New Yorker, right now we're so wildly over the boundary line in the other direction, in the direction of providing too much care, that it's hard to see how we could accept leaving healthcare the way it is. And so another take-home point is that over-treatment is equally harmful. We have financial harms, we have folks who can't afford their care, but when we're providing too much care or we're providing unnecessary care, that's harmful as well. And he wrote in his piece that waste is not just consuming a third of healthcare spending, but it's costing people their lives. And this over here is a figure from JAMA, and it's looking at, if we have somebody who experiences an overuse service, maybe they get an unnecessary lab test, unnecessary imaging, they have to follow up on those things. There's both short-term consequences and long-term consequences. Physical, how many patients do you talk to that don't want their labs because they don't want to get poked? Like, how many people like sitting in a CT or MRI scanner? Nobody likes those things. So there's physical consequences for our patients. There's psychological consequences, thinking about, am I going to get this diagnosis? What's this test going to lead to? Do I even need this test? There's a treatment burden, the fact that, maybe you're started on a treatment that you didn't necessarily need, or it's not an optimal treatment for you. There's obviously the financial burden, and ultimately people get dissatisfied with their healthcare. I mean, you'll hear hundreds of stories throughout medical school of patients who are upset, because of this doctor or this situation or this thing. And when we overuse services, that increases the chances that folks are going to be dissatisfied with their care. And here are just some additional stats, looking at that, there may be up to $935 billion worth of waste in our healthcare system annually. And that results from failure of care delivery, failure of care coordination, and overtreatment or low-value care as well. So you might be wondering, there's a lot of doom and gloom, where do we go from here? And this is a comic, I don't remember where I got it from, but it seems like I've had this conversation with patients before. I can't afford that particular diagnosis. Do you have a cheaper one, or maybe one with less follow-up, or maybe the meds would be cheaper for another one? Maybe I don't have to get as many CT scans with this one. And I wish that was an option for our patients, but it's obviously not. And so I think in terms of where do we go from here, this is the view that I hold in particular. This is as much of what we do at Cost of Care. This is what we do through the STARS program, both locally and nationally. And we're focusing on the fact that medical students, as future physicians, are really ideally positioned within the healthcare ecosystem. You interact with folks in the outpatient setting and the inpatient setting. You work with social work and pharmacy. You work with all of these kind of players in healthcare. And I think you can consider both affordability and value in your clinical decision making. And I believe this so strongly because we know from the literature that your training environment matters a lot. This kind of a string of papers here at the bottom looked at residents. And so it looked at folks who were in a high-cost residency program or comparatively low-cost residency programs. And they're caring for similar patient populations, either in like similar cities, similar demographics, things like that. And if you went to a high-cost training residency program, you didn't talk about cost, you didn't talk about value, then you were likely less cost-conscious in practice, but you spent 29% more in your first 7 years of practice as an independent physician following your training. For some patients, that's like millions and millions of dollars, or for some physicians, when you look at the patients that you care for, that's millions and millions of dollars that you've spent over these first 7 years of your practice because you went through high-cost training, because we didn't talk about these things in your residency or in your medical school. And ultimately, I think this is a medical ethics issue. This is something that we need to think about for our patients. You all remember that first day of medical school when you donned your white coat and you said that oath, and this is something that you think about. First do no harm, I think, needs to come back into our thinking. We're trained to care for the patients in front of us. We weigh risks and benefits all the time in our treatment decisions and guide patients through complex decision making. I don't know if any of you have ever sat in on a conversation over in the James where we talk about treatment options with a cancer patient, where we're talking about current first-line therapies and second-line therapies and ongoing clinical trials and radiation and surgery and the role that all those things play. And I think we can recognize that financial harms are real harms, and they can be added to this calculus as well. And so when we were thinking about, when Michael and I started the STARS program, what did we want to do? What were we going to change? Where do we go from here? We ended up developing and teaching, as I mentioned earlier, this 2-day, 8-hour experience delivered to students during their selective course week. And in particular, we taught it to first and second year medical students. And on day 1 of the course, we had kind of an intro to the course, and we looked at learning objectives. And then the first lecture for the course was the value shortfall. So the first couple of slides that I had there, we stretched them out over an hour. We talked about all of those things. And then we looked at really an introduction to high-value care. We dove into that value equation, looked at different examples and kind of its key components. And then we wrapped up day number 1 looking at the Choosing Wisely campaign. Choosing Wisely is a resource from the American Board of Internal Medicine Foundation, and they went to a bunch of different professional societies and said, hey, what are examples of low or no value care, things that we should stop doing in the hospital or clinic? And so we reviewed that resource and went over a few case-based scenarios as well. Day 2 of the course then started with tactics for assessing value in the medical literature. Michael actually had a PhD in this stuff, which was really helpful. He was able to lead that lecture and put it together. And then for the medical students in the audience, we covered my favorite journal series, which is called Things We Do for No Reason. It's published by the Journal of Hospital Medicine. And if you want to start an argument at Journal Club, bring something from this series. Because most of the time we're talking about like, hey, let's try this new treatment, or like, hey, let's do this thing. But you bring an article that's like somebody's favorite practice in the hospital, like they love the neutropenic diet, and you bring this article and you're like, there's not a lot of evidence for that. Like, and it costs money that we do this, and it's difficult for patients. And that's a great article series as well. So if you ever want to look at that, just Google Things We Do for No Reason and look at the Journal of Hospital Medicine. So we talked about a few articles from that. Dr. Haycock led a great talk looking at strategies for discussing value in healthcare, like how do we actually have conversations about these things. And then I led a lecture looking at advocacy for students and trainees and some high-value care resources as well. And then we were really blessed. A couple of practicing physicians from internal medicine, both inpatient and outpatient, family medicine, and the Department of Surgery joined us to kind of talk about their practical experiences with high-value care. What does this mean when you go out into the hospital or the clinic or OR? So that was the course that we put together, and I'll share some of the kind of the pre and post-course evaluation data in the next part of the talk. So in summary, this first part here, looking at healthcare affordability, remember that up to 1 in 5 insured Americans have difficulty paying their medical bills. Patients, when they're put in this conundrum of how do I pay for my care, they'll put off necessary care, skip tests and prescriptions, and ration medications when they can't afford their care. And this affordability crisis exists kind of amid an excess of harmful waste in the U.S. healthcare system. We have this group of folks who can't afford their care, and that's happening at the same time as a lot of wasteful care happening in our system. And ultimately, I believe, and it's what we're working on at Cost of Care and through the STARS program, that medical students are really ideally positioned to lead changes related to both affordability and value as they progress through their training. So that's kind of the first part of the talk here. And we'll save questions for the end, so please, if you have them, write them down, put them in your notes app. We'll get to those later on. We're going to talk about this framework for affordability and value and really how we take medical students from where you currently are in your medical education to being leaders in value and affordability. And this is a model that we developed at Cost of Care, and that Dr. Moriarty, our executive director, led. And it starts with the foundation of trust. This is something that we've also talked about in partnership with the ABIM Foundation, saying that, like what we do in healthcare is fundamentally relies on trust. If we're going to have conversations about cost and value, we need to build trustful relationships with our patients. And ultimately our goal, as we do this work, as we provide care in the hospital or clinic or wherever we are, our goal is that we have equity in outcomes and delivery. And in particular at Cost of Care, our goal is that nobody has to choose between their life and their life savings, so that nobody has to make that choice as they receive healthcare. And to get there, there's kind of 3 steps. The first one is awareness. This is what most of you are doing by attending this talk today, either online or in person. Becoming aware of these issues, recognizing that these are really serious things that affect a large number of our patients. And then we have to think about appropriateness. And this is kind of the idea of value, making sure that we're fitting our clinical care into our patients and into their lives and into the context of what matters to them. And then lastly, we're going to look at affordability too. Unfortunately, a lot of the work in high-value care that's happened really over the last decade has led to cost savings and things like that, but it leads to cost savings for our medical centers, for institutions, but those aren't passed on to patients. And so ultimately, our goal is that all of this work eventually leads to more affordability and improved affordability for the patients that we see every day. So first off, we're going to talk about kind of this foundation of trust and what it really means for physicians and for medical centers as a whole. Unfortunately, it's pretty well documented that public trust in healthcare leaders and institutions has declined substantially since the 1960s. And this kind of coincides with the emergence of this complex, expensive healthcare system that we now have, that you're all learning medicine in, that really emerged during the 20th century. And affordability is probably a key contributor to this decline. The public routinely hears, especially in the last 5 to 10 years, about reports of overuse, unexplainable price variability. How much does it cost to get a C-section at OSU versus Ohio Health versus Mount Carmel? Those numbers can vary widely. Excessive profits. You've heard about nonprofit institutions that are raking in millions or billions of dollars a year. Patients hear about that and wonder about that. And surprise medical bills too. There's been a lot of legislation about that lately, but that's something that patients are concerned about as well. And trust is ultimately, in any context, and when you're looking to build relationships, trust is built on empathy, honesty, and communication. And when we have unaffordable healthcare bills, when we have unnecessary tests and treatments, it really cuts across all of these fundamental aspects of building trust. And so to improve trust, to kind of go forward, really in all of our work, we want to make concerted efforts to reduce patient costs, to have that end goal of affordability. We want to improve price transparency so patients know how much things cost, so providers know how much things cost. If I'm ordering a CBC, what does that look like? How much does that cost? And then help with system navigation too. There's a fair amount of waste in our healthcare system just because we have to repeat tests or procedures. Patients don't know where to go for particular problems. There's a lot of promise in terms of system navigation as well. And there's really great opportunities for medical center care redesign to think about, how patients, really the best work in this is in terms of pregnancy. So how does a patient go through their pregnancy? What does prenatal care look like? What does delivery look like? And how can we redesign that process to build trust with patients? There are some really innovative healthcare systems that are involving patients and designing solutions to kind of address this erosion of trust. And ultimately, trust is built with both individual physicians in your individual patient-physician relationship and larger medical centers as well. And so we focus so much on this work and we focus so much on medical students because we want to prepare you to be trustworthy physicians in this domain. Eventually, you're going to go on to have one-on-one patient interactions where you're going to have these types of conversations. But we also know that medical students are going to go on to be clinical care leaders. You'll become the CEO, the CFO, the CMO of large medical centers. And we want you to understand that there's a foundational relationship between healthcare affordability and patient trust. So for those of you that do go on to be leaders in that setting, we want you to acknowledge this relationship as well. So that's kind of the trust component of the equation. That's what we're looking at in terms of the foundation of the work that we do, both through the STARS program and at Cost of Care. And the next thing that we're going to look at is awareness. So are people aware of these issues? Is this something that's even on your radar as you're, talking with a patient or making an assessment and plan, for rounds? This is the next goal in terms of awareness. And for us, really through the course, because of our connection with the STARS program and the STARS program, using Choosing Wisely as a primary resource. This is the 2020 course data here. We asked students, have you seen or heard about the Choosing Wisely campaign before and after the course? Or have you seen or used any Choosing Wisely materials before and after the course? And the percentage of students who had after the course it went up statistically significantly, which is great because hopefully you were attending the course and paying attention to these things. This was taught on Zoom, so those no people might have, I don't know, not been looking at the computer or something like that. But we also looked at the percentage of students who correctly answered 3 questions about healthcare overuse. So we kind of tested their knowledge there, and that went up as well. And then for the 2021 course, which was taught in person, 100% of the students reported seeing the Choosing Wisely campaign and its materials following the course versus just 4% before. And students were, again, more likely to answer healthcare overuse questions correctly. So we're kind of doing our job throughout the course of building awareness for these issues. And then I don't think Lily's here from our 2022 stars, but some of our other 22 stars as well. They led a really cool project this year, looking at piloting an introductory high-value care lecture as part of the longitudinal group curriculum. So this is something that we all went through, in our first and second years of medical school, and they gave this lecture. And then after that, they sent out a post survey and they said, hey, like, when do you want to learn about these things? Like, if it was up to the students, like, when do you want to learn about these topics? 131 students responded to the post-lecture survey, and the greatest percentage of students wanted to actually learn about high-value care during Foundations 1, which is interesting because at the national scale, one of the greatest critiques of our work is that people say, A, we shouldn't teach this to medical students, and B, there's no way you should teach this to preclinical medical students. Like, they should be learning the Krebs cycle, they should be focused on anatomy, like, they don't need to learn about these topics like value and affordability. But when you go and ask the preclinical medical students themselves, when you're like, hey, you experienced this like in your first year of medical school, when do you want to learn about it? They actually want to learn about it right away. The next most popular options after that would be endo-repro. I think there's a lot of good opportunities for discussion there in terms of diabetes medications and the cost of those types of medications. Then Foundations 2 after that, the musculoskeletal block and cardiopulm as well. So in terms of building awareness and like when students really want to learn about these topics, I think we're going to see a growing number of students who want to learn about these topics, starting from day one of medical school. Next, in terms of our framework for affordability and value, things that we're thinking about is appropriateness. And this is kind of a hard one to define, but ultimately it ties into this notion of value. Like, what are patients getting? What are the outcomes that matter to patients? And what are we paying for those outcomes, or what are patients paying? And so we assess students pre and post-course. We looked at their attitudes regarding value and cost-conscious care. We looked at the barriers that they thought about in terms of providing this type of care, and then the consequences of implementing this approach. So what would be the positive things that came out of it, and what might be some negatives as well. And we based this off of a paper that was published by Dr. Moriarty and a couple other folks looking at medical student attitudes towards and experiences with cost-conscious care. And in 2020, students demonstrated shifts towards value and cost-conscious attitudes for all 21 survey items that were assessed, which was really great to see that students were changing their thinking about kind of value and cost-conscious attitudes and actions. And then in 2021, students shifted towards value and cost-conscious attitudes for 4 out of the 21 survey items that were assessed. For the remainder of those, the distribution of responses shifted towards these attitudes, but it didn't reach statistical significance for that cohort. So this is something that we're constantly thinking about in our teaching, like, are we helping students shift into thinking about value and cost-conscious care, and kind of to what degree are we doing so? So that's appropriateness. And really, I think that's something that we need to explore more in the M3 and M4 curriculum. Do students think about, like, what's the appropriate test, what's the appropriate treatment for this particular clinical context? So that's something that we'll be working on as well. And then lastly, there's affordability. This is the ultimate goal, that our healthcare is more affordable for the patients that we're seeing. And I really wish we had cool data to show here. Unfortunately, you think about kind of like the methodological rigor that would go into tracking students who go through the course, and then tracking the teams they're involved in, and then are they spending more money or spending less money? And that's what actually went on in those papers that I showed you earlier talking about residents. It would be really cool to publish that, but obviously very methodologically difficult. So instead, we asked students about their self-efficacy. And we said, hey, like, you're going to go on and be, a resident physician in just a few years. You're going to be an independent practicing physician, in just a few years beyond that. Like, do you think you can do this? Do you think you can practice high-value care? Do you think you can use the information that we shared with you? And in terms of integrating high-value care practices into their clinical practice, students improved in that domain. In terms of effectively integrating information about high-value care into clinical decision-making, students improved there as well. And then ultimately, in terms of finding information on high-value care that could help inform clinical decision-making, students made really large strides in terms of their self-efficacy and kind of their feelings about whether they could do these things in the future. And this, again, is our 2020 course data. We're still working on some of our 2021 course data, but kind of our preliminary analysis showed similar and statistically significant results as well. So that's kind of, it doesn't say that they're ultimately going to provide more affordable healthcare, but it gives us some hope, that students think they can do this in the future. In terms of affordability, then, other future directions, this kind of the future directions portions of the talk. We're going to teach and assess the course again in person during this year's selective weeks. So if you're a first or second year medical student, you'll definitely have the opportunity to sign up and learn from our 2022 stars as they teach the course. We'd like to obtain follow-up data for our 2020 and 2021 cohorts. Most of them have completed their clinical rotations now with M3s and M4s. Dr. Hickok's giving the thumbs up, so we'd like to work on that. Because it's one thing to learn about these things in the preclinical setting and maybe to talk about it in LP, but what happens when, you're waking up at 4:30 a.m. for your surgery rotation and going into round? Like, are you thinking about value and affordability then? So that's something that we'd like to explore as well. We'd like to evaluate additional opportunities to teach high-value care and affordability concepts, to facilitate spaced repetition. That's the learning concept that's kind of at the core of all of you Anki users. We'd like to improve retention of these topics and then boost self-efficacy as well for students kind of across the board. And then lastly, we want to continue to support student-led teaching initiatives in the LSI curriculum. This is particularly important for us because we know that those students are going to go on to be leaders. And, whether they're just, leaders without a particular title in their clinical department or their residency, maybe they go on to become a chair or a CEO or CFO or any of those things. We want to continue to support students and their teaching initiatives in the LSI curriculum as well. And ultimately, we can't forget what our final goal is. What are we working towards as we do all this? And that ultimately is equity and outcomes in delivery. And so I know there's been a lot of doom and gloom in this talk, but there's some really positive news in this space as well. There's lots of folks who are working on lots of different ideas to tackle health insurance costs, to make health insurance more affordable for middle income or low income Americans. President Biden just announced at the beginning of August that we're at an all-time low uninsured rate. Insurance is not a perfect system by any means, but it fits into kind of the affordability picture and how we make sure we provide affordable care for folks. And then one thing that excites me that many of you have probably heard about is Mark Cuban's Cost Plus Drugs Pharmacy. I think this is really going to be a game changer. And we've been talking about it at Cost of Care and through the STARS program, what this means for folks. How do we educate students about this opportunity so that folks can access this resource as well? I think that's something to keep an eye on as well. And ultimately at Cost of Care, this is kind of our driving force. This is our mission. We call this our affordability moonshot. Our goal is that within the next 10 years, we envision a future in which no one has to choose between their life and their life savings. And if you're a student and you're thinking about affordability and you're thinking about value, and you're getting up for your third year rotations and it's 5 o'clock in the morning, this is what drove me. This is what I was thinking about, a future in which no patient has to choose between their life and their life savings for the chemotherapy, for their surgery, for their care they're receiving after a heart attack. I think that this is a really inspiring vision and something that we're doing at Cost of Care. So I'll refer you all to our website, costofcare.org, if you want to learn more about kind of the specific things that are going into this as well. So that's kind of the framework that we use at Cost of Care. That's really what guides a lot of the things going on in the STARS program. But like I said, this is sort of my senior send-off. I've got a few more months here at the College of Medicine. So I figured I'd put a few challenges out there. Students either online or in person here. If any of these things excite you, we should talk about it because there's not enough time for me to do this work, but there should be enough time for you to accomplish some of these things. The first challenge I have relates to cost conversations, and we're doing this through our selective course. We kind of started this with our high-value care, longitudinal group pilot project, but I think we need to train every medical student to have conversations specifically about cost, affordability, and value. And these are some modules that we have available on the Cost of Care website. They talk about having value conversations with other clinicians. There's also some resources there for having value conversations with patients as well. And then there's another particular strategy called the Got Med strategy. This was developed by some folks at Cost of Care. It's what we teach in our course. And it includes different strategies for saving money, in particular when it comes to medications. And I would add, for the discount drugs, now the Cost Plus Drugs Pharmacy is something we can think about as well. But I know some of you have probably learned the spikes mnemonic, you've gone through that for learning about difficult conversations. I think if we can teach students that, we can certainly teach you to have conversations about cost, affordability, and value as well. So challenge number 1 there is cost conversations. Challenge number 2 revolves around screening for harm. And this is something that I've tried hard to do during 3rd and 4th year rotations. It's not easy by any means. But I think it's important that we screen each patient at each encounter to determine their financial risk and preferences. This is like a 30-second process. If you're a student, please write these down, screenshot them, and do something with them. Save these 2 questions in terms of how to screen for financial harm. The first question that I ask is, are you worried about how your medical care will be paid for? And the second question is, are you having trouble paying for your medications at home? My favorite patients to ask these to are actually the patients where you ask these, and they're like, oh my goodness, no, I have great insurance, I'm able to afford everything, but thank you for asking, because I would want to have this conversation with my doctor, if this was a concern. I don't know how many times, I've had patients both at Children's and here at main campus, where you bring up these questions and they're like, yeah, like I want to talk to somebody specifically about these things. So you, as a medical student in the team, whether you're in the clinic or the hospital, you're the one who probably has the time to ask these questions. And I really encourage you to adopt a universal approach. It's easy to look at people, it's easy to stereotype them based on the clothes they're wearing or the insurance that you see in their chart or whatever it may be. But I think, asking these two questions to everybody, worst case scenario, somebody says like, no, I'm good, like, thanks for asking. So I think that's an important thing to consider as well. And then as providers and as providers in training, we need to understand the financial ramifications and the value of the recommendations that we're giving for different tests and treatments. And that's kind of a process that takes place over time and ultimately for most of you will be specialty specific. I don't know what things cost in ophthalmology. I don't know what things cost in other fields. But as someone who's going into psychiatry, I'm well aware of how much a long-acting injectable costs versus an oral formulation, for example, for antipsychotics. And then I think it's ultimately up to us to really optimize our care plans for individual patients to make sure that our care plans are meeting their goals, and that the money we're spending and that the money that they're kind of spending in terms of healthcare dollars is going towards their goals. So challenge number 2, I think screening for harm is important. Challenge number 3, I think we need to build response processes. I had a resident once who told me that if something is important to you clinically, you need to build a system for it. So if you want to make sure that, you always check a patient's blood pressure or that you're always checking eyes and O's, whatever it may be, that you need to build a system for it. And I think we need to build affordability screening and response into our existing clinical processes here at the medical center. And this is probably the project that excites me the most. So if somebody wants to take on this one, I would love to see this put into action. And this is from some of our colleagues at the Memorial Sloan Kettering Cancer Center. They have a financial toxicity order set. And so this may be a foreign concept for students who aren't out into the clinical setting yet. But an order set is basically, you have a patient with TKA, you have a patient with COPD, and it brings up all these like labs and tests and treatments and things that are relevant to that particular clinical condition. And the nice thing is you just type in the order set, you hit a few buttons, and then you have everything you need for that patient with that particular concern. And so at the MSK Cancer Center, they actually have an order set for financial toxicity. So if a patient, is concerned about their insurance, they're concerned about their ability to afford care, you type in financial toxicity order set and this comes up, and then you have the opportunity to connect them with pharmacy to discuss their meds. It connects them with people to talk about insurance. It connects them with social work, housing, transportation, all of these things. And all you do as a busy medical student or as a busy physician is press the button for the order set. So I think that's something that could really be beneficial for our patients and would be something that we could certainly implement here. Challenge number 4 then is affordable cancer care. Much of the research about financial toxicity and about affordability actually came from cancer patients and from people's experience working with cancer patients. And I think it's on us to ensure that affordability is a top priority for our cancer patients at the James. This is probably one of the areas of the hospital where I've had the most cost conversations with patients. And I wanted to highlight this recent publication from, I believe it's the Journal of Clinical Oncology. They did a financial toxicity screening program and intervention as well for patients with hematologic malignancies. So these were patients who were being seen in a clinic for all sorts of heme malignancies. And in patients with high-risk disease, so they used whatever relevant classification system, the risk of death in those receiving the financial toxicity intervention was 0.44 times the risk of death in those without the intervention after you adjusted for race and ethnicity. In other words, this improves survival for cancer patients. I don't know how familiar some of you are with evidence-based medicine and how it applies to hematology and oncology, but there's a lot of things that have a pretty questionable evidence base. Like maybe we do a treatment and it shrinks the lymph nodes on the scan, or maybe this will give patients a month to live. But we have interventions like this that we can implement in our hospitals and clinics that help improve survival for patients kind of across the board. And it's not a new chemotherapy, it's not radiation, it's not surgery. It's simply asking for and helping them with financial problems. So challenge number 4, I think for us is affordable cancer care. And challenge number 5 then, I think is broadly speaking is leading the way. I think OSU, I think the students in this room, anybody who's online, we really have an opportunity to become a national leader in providing high-value, affordable healthcare. We're all going to work now in the shadow of this giant new hospital. If you log into our websites, they say things like we're driving breakthrough healthcare solutions to improve people's lives. The College of Medicine here, the world is changing, medicine is changing. We're leading the way. I think if we really want to live out these missions and we really want to do these things, then high-value, affordable healthcare needs to kind of be at the forefront of that. So that's what I have in terms of today's talk, in terms of challenges. Some acknowledgments, though, folks at the Cost of Care team and with the STARS program, Dr. Moriarty's in September in particular. So Dr. Moriarty is our executive director, and then September is our operations director. In other words, she's the glue that keeps Cost of Care together. I think the program and STARS would fall apart if it weren't for her diligence and really taking a lot of action to keep us on track. folks at the OSU STARS program, in particular Dr. Haycock and Dr. Abraham for their mentorship, and then Dr. Yeager, who's now a first-year family med resident here at OSU. Our 2022 STARS, they're working on a lot of cool projects, so I'd encourage you to chat with some of them. If you encounter them either in the clinic or here in Miling or Graves. And then 2021 STARS, who now are all out doing their third-year rotations. These folks are really knowledgeable as well, and I encourage you to chat with them if you have any questions. And some organizations to acknowledge as well, certainly the College of Medicine, the Dell Medical School at the University of Texas at Austin, the ABIM Foundation, Josiah Macy Jr. Foundation, and our colleagues at Choosing Wisely Canada. They funded and supported a lot of this work. And then the High Value Practice Academic Alliance as well has really kind of welcomed us with open arms and given us the opportunity to talk about these topics. So I think that's it for my talk then. Any questions either in person here or online? Yeah.
That was a great talk, super interesting. I had a quick question.
Mm-hmm.
So you talked about learning environment and people who trained at a high cost residency and low cost, and that just kind of led me thinking, are there any tools available for people to kind of check their metrics if they're a high cost or a low cost provider, how they're doing?
Yeah, so there's a lot of work going on, I know, at the medical center, and it's pretty department specific and looking at that. And that's something that's important because ultimately, it's interesting when, I think this is mainly happening in the Department of Surgery, to my knowledge, in terms of using materials in the OR and how long folks are in the OR and things like that. Do you really know if you're a high value care or low value care person? You're okay, I spent $20,000 on this operation. What did my colleagues spend? And so I think it was one of the graduating residents, actually a year or two ago, developed a value dashboard. And so it's a website where you can plug in certain patients and things. And they looked at that and people were to say for a lab chole, what does it cost me versus my colleagues? So I think things like that you're going to see kind of developed and used more often. I don't know if any places have them available for residents in particular, but that would be helpful to know, or maybe even just for the cases residents were involved with to see we used a lot of materials in that case versus this one, what does high value care versus low value care look like? So yeah, was there another part to your question?
Yeah. This is a really simple question, and so you talked about some of the financial consequences of medical bills, and I totally understand not being able to pick up prescriptions and things like that. Just for my own learning, what are the consequences of consciously choosing to not pay a paper medical bill? If they're oh, here's a $10,000 bill, and someone's I'm just going to ignore it. What happens to that person?
I think it varies a lot depending on the institution and the state. So institutions vary widely in how much they're willing to pursue somebody legally for those bills. And I would encourage you to Google it to read stories about it. But there are some institutions that have gone after people and seized homes, seized cars, things like that, in order to have patients pay their bills. Which when you really think about it, you look at our mission statements, we're driving breakthrough healthcare solutions and the world's changing and we're going to lead the way. Is that consistent with what we want? Or with really what any healthcare institution would want, so they do that. And then the other unfortunate thing is that I believe it's primarily state dependent in terms of how medical debt is passed on, in terms of an inheritance type thing. And the really sad thing is that there's a significant number of states, in particular, where children's medical bills can be passed on. So if you have a child who dies away from cancer and you essentially inherit that debt and then you pass away, that can even be passed on in your family. So those are things that we think about in terms of affordability. So yeah, I'd encourage you, if you're looking at institutions, especially to work at someday, to be what are your policies on these things? How do we help people? And it's especially, I think it's really difficult for patients when we have situations where somebody's been sued or they go after somebody to pay those bills, and then 6 months later we see that OSU or whatever hospital has a $1 million or $1 billion profit. It's what does that mean for the patient where you took their car or you took their home? I think those are really serious kind of societal things that we need to think about. So yeah, thanks for your question. Yeah.
That was an excellent talk.
Thanks.
Kind of going in line with the first question that was asked, have you or others initiated conversations or initiatives with Epic and IHIP for integrating cost of care into lab tests and formularies and whatnot?
Yeah, that's kind of an ongoing discussion here at OSU and nationally. For example, I think at Johns Hopkins now, they have a program where their Epic will take into account your particular patient and their insurance, and almost kind of prior auth or pre-auth it as you're ordering things to see give you a rough estimate of how much that CBC or that CT scan is going to cost them. And so I don't think we haven't made a ton of progress on that here at OSU. But I think it's something where, ultimately it would be nice to see, when I click through an order set and I'm adding things or, I'm making decisions as a healthcare provider, what are the actual dollar amounts associated with that. And I think, speaking to kind of like being able to like act on these things, like we need to see that like, the daily CBC that you have for a patient, like, what does that look like versus getting it, every couple of days they're in the hospital or things like that. So ultimately, I think that will help people really put this stuff into action. Yeah.
Thank you so much. This may be overly simplistic, but a lot of the conversations I've heard about reducing waste are on the environmental side. And I'm curious about like the high field waste reduction strategies from an affordability perspective. Obviously, pharmaceuticals is probably the highest, but are there any that overlap significantly with some of the high yield environmental waste reduction strategies, or is that like plastic not maybe on that affordability side?
I think the obvious overlap is in terms of materials, and this is especially true like in the OR setting and things like that, like what materials are we actually like using for patients during particular procedures or surgery. So I think that's kind of the immediate overlap. I think the next one, that comes into play is probably imaging. How much electricity does it take to run CT and MRI scans and do things like that? And so if we're duplicating imaging or getting unnecessary imaging, like what's the environmental impact of that? I think really the last one is lab tests. And you'll encounter this when you get out into the hospital, like how many times do we order lab tests that don't change anything for the patient or that wouldn't change anything in their care? And you think about the number of those little plastic tubes we use, especially at an institution like OSU. There was a shortage of those not too while ago, and everybody was freaking out. And it's like, well, like what if we just stopped doing those lab tests? Like, would it actually change things? And so I think there's kind of all those overlaps. And if you're interested in that, you should definitely chat with some of our 2022 stars. They're actually, I'll talk about it on the next slide, they're developing an advanced competency. And a lot of that has been informed and been kind of in partnership with some of the sustainability groups here at OSU. So that like as we talk about these, we also consider, the climate impact and sustainability impacts of what we're doing. Yeah.
I've heard a lot about price lists and like, you getting a bill that's like not itemized. I'm curious like whether OSU and like the rec center have like itemized cost lists that you as a like medical student or even a patient can look up. And then the other question is like, okay, what is that question? You know, it's like when you're a student and you're with or a provider and you're with a patient, like can you look up costs and tell them, like, do we have patient care coordinators who do that? Do they have, I'm thinking about, like, the timeline, like, when people agree to treatment or don't agree to them. So, like, if you're with a patient in the room, like, do we have people that can help them with insurance? Are they external people that have to come in? Can you, as a provider, like, look up costs and, like, yeah.
Yeah, so for your first question, there is, and we can look at it too before we leave, there's a price list available on the Medical Center website, and I think we now have a price estimator as well, or that's in the works, where you can plug in like your particular insurance plan and kind of what that would mean for you. And that kind of comes on the tails of lots of national legislation about price transparency and things like that. The really fascinating thing is the number of places that don't have that. I think across the National Cancer Institutes, like federally designated National Cancer Institutes, it's something like 40% of hospitals like meet those requirements. So that means 60% of the places where patients go for like the top-notch cancer care in the country like aren't providing this information, or like patients really have to dig to find it. There's also been some legal issues in terms of institutions hiding those things on search engines, so that if you Google, price list at this institution, like it doesn't come up in the top list, and that's by design. So I think those are really serious issues to consider. And again, like when you choose an institution to work at today, like what's their attitude towards that? But we do have that available here at OSU. And then in terms of, like point of care knowledge, like we kind of talked about with our other question, at least at OSU, that's not an option currently. But, you'll encounter, I think it's, there's like patient care navigators and social work and folks like that who can provide a little bit more information about how somebody's insurance or insurance status kind of has an interplay with that. And I encourage you to think about like really the timing of care and like, if we're, for somebody with like chronic back pain as an example, and like somebody's interested in imaging, like how does that fit into like the natural history of their disease? Or if somebody's in the hospital, like do we have to do this test today, or could we, check on the price, consider those things and consider doing it tomorrow? I think lots of times we have we have urgency or we try to take action quickly because it's easier for us as providers, when in reality, like, we don't deal with the financial burden of it, patients do in the end. So I think that's something to consider as well. And in particular, as a medical student, one thing may be that you ask these screening questions, but you don't always have the answers for how to help. And so that's when making friends with your social work and your pharmacy colleagues and all those folks will be really important. Especially over at the James, I encourage you to get to know your pharmacy colleagues. Lots of times they know about prior auths and they know about like medication assistance programs and things like that. So they can be really helpful.
We have time for one more question. Does anybody have one? If not, no question.
If you want to get involved with other things in the future, again, we have 2 presentations coming up at the High Value Practice Academic Alliance meeting. These will be led by our 2021 stars and 2022 stars. You can register for that meeting online if you're interested. And then in terms of upcoming OSU stars kind of projects and initiatives, again, we'll be teaching the selective course here in fall 2022 to both our first and second year medical students. So if you have mentees, folks in those classes who are interested in these topics, they can get kind of the deep dive there. We're also starting a student interest group. So say you don't want to be involved or you don't have time to take the courses through the formal curriculum, our student interest group will be working on stuff kind of outside of the curriculum. And then our 2022 stars, again, are working on developing an advanced competency and looking really specifically about how we can do those things. I think it'll probably be like a longitudinal one done over time where you can kind of work on these things throughout your time in medical school. And then we're recruiting for our 2023 stars cohort as well. Again, it'll be virtual, so we don't get to send you to Austin, but that's an opportunity as well if you know folks who might be interested. So I think that's it. And then this is the last part. I'm supposed to put up this QR code for feedback, and you also have the opportunity to provide your email address if you're interested in learning more about these things. So, thanks, everybody, for coming today. Right. We need to stop recording. There you go.